Hello there. Good morning or evening or whatever time of day it is. I wanted to do a follow-up video to an all-on-4 case that I've started and we're getting ready to deliver this week. Pretty exciting. This is a case that I partnered with my oral surgeon in office to go ahead and plan the case. She placed all the implants, did all the reduction, and then we converted his temporary dentures to immediate temporary hybrid restorations that he has worn for about 5 months. So, the final part of that process, of course, is taking some impressions. We used, looks like we used an open tray impression process. Here is the lower right here and the upper right here. These are open tray impression copings that are embedded in there. And you can see on the other side where the access holes for those screws that came out of there. So these are the impressions, look pretty good. We took these a couple of different times, and this is the best result that we had. Now I should preface this by saying that he had temporaries that he had been wearing that he was very pleased with from a cosmetic standpoint. The lab that we used, a local lab here in St. Louis, really nailed it. They did a great job aesthetically with creating that partial, or that temporary. This is one of the mock-up of the temporaries that he was wearing. But normally when I send those cases to the lab, I always, when we're doing an immediate temporary denture of any type, I'll communicate with the lab and let them know I want them to use the current position of the teeth if it's acceptable, and the size, and then of course we pick a shade. That way they're actually cued in to replicating the patient's current tooth size. Sometimes we can measure it and send them pictures, and we've got another case that we started yesterday that we've done that. We've got a couple of pictures from where we're sending that to the lab. But one of the things, in addition to the impressions, again, open tray impressions, multi-unit impression copings there. These are Nobel active implants with the multi-unit abutments on them, and those are, like I said, the copings. So that will show through on the tray here. So the conversion process, I'm pretty comfortable doing that myself. I can convert an upper and a lower in about an hour. It's not too difficult. The process that I like to use is once the implants are placed and we find the right multi-unit abutment, the angle and the height, those are put in place, and then I use a bite impression material or a heavy body fast set impression material inside the patient's existing denture. And I'll put it in the mouth with the impression material, and it captures where that abutment is. And then we'll drill through the denture and convert that denture through a standard process. I like to use chairside reline or pickup material called Easy Pickup. It's great. It works really, really well. So then we get to the final prosthetics. Now these are still attached to the model. These are all zirconia prosthetics. They look pretty good. See if that black background helps a little bit. They look really good, really nice. The extension on the palatal side here is minimal as compared to what he was wearing before. He's going to be very happy with these. So one of the things that I really like is how they've contoured internally. I guess the interface with the gingiva, how nice that's going to be. Here's the lower. There's a little bit of thickness here, but that's to accommodate the zirconia as it pertains to, or as it relates to where the implants are. So there's titanium embedded, bonded into the zirconia. So again, a very nice outcome. And when we put these together, you can hear some clinking. Zirconia almost always has a little clink to it. But there's the final outcome right there. Very nice outcome. Many of the ones I've done in the past have been acrylic with a titanium framework. And so you'll send, the lab will send back a titanium framework with wax on it for a try-in. And it's hard sometimes to take that titanium framework out of the patient's mouth because they're so excited about the permanent long-term prosthetic. In this case, we really didn't need to do a wax try-in, but we did anyway, just to make sure the patient was happy with it. And I'm really glad that we did. The camera may not focus well, maybe I can catch it with the glare, with the reflection. The facial of these is very smooth now. The initial proposal the lab sent us, the wax try-in, there was quite a bit of mamelon, quite a bit of facial lines of imbrication and mamelon there. So it was something that the patient did not like, and so I'm really glad that we did that wax try-in. Otherwise we would have had to process these, and then everybody would have been disappointed because we would have had another week or two waiting. But we tried him in, and he requested that we smooth those, and in retrospect I'm very glad that he did. This looks much better. Yes, so here is the case. Get those to line up right. An all-on-4 case. Some learnings that I've got from this case. Make sure you plan your immediate temporaries well. You get the shade correct. If you can, if the patient's missing some teeth, maybe the majority of teeth, try to do a wax try-in with those teeth to make sure that everything lines up. Prepare the patient long-term for the process, and make sure that they realize that when they're wearing the temporary, they have to limit the food that they eat, to soft food. You know, nothing more substantive than like mashed potatoes or scrambled eggs. Occasionally we'll have a patient come back who's broken, you know, their temporary, and again this is a mock-up of that temporary. And it's primarily because they have not been following the rules. They've been eating almonds, or they've been, you know, eating routine food, and it's easy once you get past the initial healing time frame to forget. So we have to remind them. So that key takeaway. Making sure that the patient's prepared for potential delays from the lab. We've had some heavy delays. To go from the impression appointment to the wax try-in appointment took about a week because it was just going straight to wax on denture base. But to go from the wax try-in appointment to the final prosthetic delivery, which we just took delivery of, took almost 5 weeks, which is unheard of in my experience. And it was not that the lab wasn't doing their very best to accelerate things and get the process going. It was just delays. You know, I don't know if there's a shortage, chip shortage is causing any of this. I don't know if there are other issues or shipping challenges or what have you. But there were a lot more delays in this case than I've ever experienced in any other full mouth reconstruction case. But make sure that the patient is aware that we're in this for them. Dr. Gordon Christensen said once at a little pre-Midwest Dental Conference meeting that I was at with a few other guys from my dental class, he said, the more you do for a patient, the more likely you are to feel like you're married to them. You know, the more crowns that you do, the more work that you do. When we do a case that involves a full mouth of implants and you know, fixed prosthetics, we're essentially becoming more and more connected to that patient. So you have to be prepared to deal with some of that. Anyway, that being said, we're all about patient connection and creating patients for life. And in this case, you know, everything went really well. Long term, we're anticipating a very good relationship, and making sure that everything going forward is in the patient's best interest and provides an excellent aesthetic outcome. So my protocol going forward after this will be to have him back every 6 months, but once a year we'll take the screws out, clean around them, clean underneath the prosthetic, of course, and then replace the screws as needed. You know, multi-unit abutment screws are not expensive, but the problems from a failing screw can be, so you're better off replacing them more frequently than you need. And it's a pretty simple process. So thanks all for watching. Please let me know what questions you have. I'm still, just to probably head off a question that may come, I'm still in the process of reviewing the literature that came from the Ivoclar rep as it pertains to Emax versus GC initial lysi. And so I'll keep you posted as I have more details. But please let me know what other questions you have. Thanks for watching.